Excellent. Thank you all for joining us, and thank you to the panelists for being part of this important conversation. I'm going to hand over to Professor Andre Mochan, who's the head of neurology at BITS, to start us off. Andre.
Yeah, thanks, Kirti. And again, thanks for that, for the progress on our weekly meeting, not weekly, monthly meetings, and it's really revealing going forward. And we hope to put this together in some other shape or form. We've already had some discussions. Welcome everyone for joining, really. It's an honor to be hosting this from BITS, and it's not through my merit, but it's Kirti's initiative, and we're glad to partner with it. Without further much ado, I would like to hand over to you, Kirti, and really thank you again for putting this together, and I'm glad and proud to be part of this. Thanks everyone for joining.
Thank you, Andre. So just briefly, in terms of brain health, we're looking at brain health in a cohesive way. So what do we need to do to actually keep the brain healthy? And I think the economic challenges that we all potentially face are quite huge, and we all are sitting with quite high levels of food insecurity, particularly in vulnerable populations who do see us in state hospitals. And I think it's such an important conversation to have, and an important factor to include in brain health and approaches to support brain health and mental health. So really am excited to have the three panelists who have agreed to join us. Your work is really incredible. And yeah, it's to highlight this work and highlight approaches to mental health that have to be more systemic and strategic for us going forward. We're going to start with the first speaker, Professor Dorrit Posel. And Dorrit holds the Helen Suzman Chair in Political Economy and is a distinguished professor at the School of Economics and Finance at Wits University. She was based previously at the University of KwaZulu-Natal and completed her PhD at Amherst University in the USA. Her latest research is one of the reasons that Dorrit is here. It focuses on mental health and explores the implications of job losses for mental health and gender differences in the vulnerability to depression. Over to you, Dorrit. Thank you.
Thanks, Kirti. I'm just going to share my screen. Okay, I hope everybody can see this. So good afternoon, colleagues. In my 12 minutes, my allotted 12 minutes, I would like to address two questions. The first is, what are the implications of unemployment for people's mental health? And the second is whether women ruminate more or suffer more mentally from economic hardship than do men. Because I have to be very brief, I just wanted to highlight the two papers from which the presentation is drawn in case you want more detail. And this is collaborative work with two colleagues in the School of Economics and Finance at Wits. Okay, so let me start with the first question, which will form the bulk of the presentation, which is, what are the effects of unemployment on mental health? And there's a very large literature which explores this question. There are several systematic reviews. I've listed some there on the slide. And there are many studies that identify that people who are unemployed are more vulnerable to depression or experience more depressive symptoms than people who are employed. But the problem with much of this research is that it's very difficult to identify the direction of causality in this relationship. So people are wanting to test that whether job loss or unemployment leads to depression. But it's quite possible that when people are depressed, they find it much more difficult to retain or to find a job, which in turn leads to job loss or unemployment. In other words, it's quite possible that the causality runs in the reverse direction. And this problem of reverse causality is a very difficult problem to remedy, even if you have longitudinal data. The typical gold standard that studies use is they look at the effects of factory or mine closures on mental health, because then the source of job loss should be exogenous to the individual, or it shouldn't depend on the individual's mental health, so you can rule out the reverse causality. But the problem is that detailed data coming from factory or mine closures on individuals and their mental health is very difficult to come by. So as terrible as the COVID-19 pandemic was for people's economic livelihoods. The hard lockdown, because of the crisis, provides us actually with a unique natural experiment, because the large-scale job losses that resulted from the COVID-19 hard lockdown in South Africa, which were estimated at being between 2.2 and 2.8 million just over the period of the hard lockdown, these job losses we can assume were largely exogenous to the individual or independent of the individual's mental health. In addition, the response to the COVID-19 pandemic offered unique labor market effects that we can study, because during the hard lockdown, most economic activity was suspended, but it was suspended in an anticipation that at least some activity would resume. And this means that we can distinguish not only between people who lost their jobs and people who retained their jobs, but we can also identify people who had what we call job furlough. In other words, people were not working, they were not being paid, they were employed, or they thought they had a job to return to. And we can also identify people who were on paid leave, because the response of many businesses and firms and organizations was to require people to take their paid leave during the hard lockdown. So people were not working, but they retained their employment and they were being paid. And this means we can start to probe what aspects of employment are protective of mental health. The data for the study come from the NIDS-CRAM survey. Perhaps you've heard of it. It's the National Income Dynamics Coronavirus Rapid Mobile Survey. It was conducted for the year of COVID-19, the first year. The first wave of NIDS-CRAM, which was undertaken in May, June in 2020, collected data on individual activity during April 2020. And the second wave collected data during June, on activity during June 2020, when we had in South Africa moved from the hard lockdown or alert level 5 to level 4. It was a very short questionnaire, obviously, because of the circumstances. And so the 2-question patient health questionnaire was included, although only in wave 2, not in wave 1. So all adults were asked over the previous 2 weeks, did you have little interest or pleasure in doing things? And had you been feeling down, depressed, or hopeless? There were 4 response options provided, ranging from not at all over the previous 2 weeks to nearly every day, where each response was scored from 0 to 3, giving a total score when added together of 0 to 6, which we rescaled to 4 outcomes to satisfy various assumptions for the regression analysis. And you can see the 4 outcomes there, 0 being reporting no depressive symptoms over the previous 2 weeks. The PHQ-2 is it's a crude measure of depression. It's not very nuanced, but the PHQ-9 has been validated as a reliable screening measure for depression in South Africa. And in the study, we focus on a continuum of distress rather than imposing a threshold above which we can say people are depressed, which is consistent with the range of studies for South Africa. The sample for our study was all adults who reported being employed before lockdown. So everybody that we consider had a job before the lockdown. They had a job in February 2020. So we have information on 2,213 adults in waves 1 and 2. We have complete information, including their response to the 2 questions of depression. And just to give you an idea of the implications of the hard lockdown, amongst all adults who were employed in February 2020, only 41% were working in wave 1 in April, 17% were on paid leave, about 12% were furloughed, so not working, not being paid, but they thought they had a job to return to, and about 30% were not working, they had lost their jobs. In wave 2, so moving to lockdown level 4, the share of people working had increased to about 57%. The share on paid leave had fallen to 6%. The share on furlough had fallen to 5%, but the share not employed had increased to 32%. In other words, some people who thought that they had a job obviously lost their job by wave 2. So I'm sorry for the table, but it's just easiest for me to talk to the results so that you can see the output. This is simply the marginal effects of a regression analysis. We estimated logit regression, so the dependent variable was your score and the PHQ-2, which we'd rescaled to 4 options. And this tells us, the marginal effects tell us the likelihood of you reporting a particular outcome relative to the base category, which is individuals who had lost their jobs. So there are two regression specifications. The second one just includes additional covariates. This is not disaggregating amongst the employed, so it's including people who were employed on paid leave and furlough. And you can see that in this specification that employment is protective of mental health. People who were employed in wave 1 were 5% more likely to report no depressive symptoms compared to people who had lost their job. And if people were employed in wave 2, I'm looking at the first regression specification, then they were 6% more likely not to report any depressive symptoms relative to people who had lost their jobs. But when we disaggregated amongst the employed, we saw that not all employment states are protective of mental health, and in particular, people who were furloughed, so people who weren't working and weren't being paid, but thought they had a job to return to, had no protective effects on mental health. The most protection of mental health came from being in paid leave in wave 2. So that was the wave when information on depressive symptoms was collected. So if people were on paid leave at that time, then they were 11% more likely than people who had lost their jobs to report no depressive symptoms, although there were also protective effects from having been on paid leave in wave 1. So briefly, by way of a summary, among a sample of adults who were employed in February 2020 before the hard lockdown, we found that adults who retained employment during the hard lockdown reported significantly lower depression scores on average than adults who lost employment. And this is an important reminder in a country like South Africa, where we have persistently high unemployment rates, that the consequences of unemployment are not only economic. The second finding was that the implications of unemployment for mental health are compounded over time, because people who had employment in each wave reported significantly lower depression scores. So if you aggregate this, you can see the implications of unemployment would have been compounded the longer the period of time over which people were unemployed. But we found, thirdly, that disaggregating among the employed showed that there were no benefits to being furloughed. So it was not helpful for people to be not working and not earning, even if they thought they had a job to return to. And then finally, we found that being on paid leave was most protective of current mental health, although paid leave had protective effects 1 to 2 months later. All the other covariates that we included in the regression analysis had the expected signs, with two exceptions. The first was that African adults reported significantly lower rather than higher depression scores. Higher depression scores are typically found in all studies of mental health in South Africa. And women reported not significantly different scores from men, which is also very unusual. And a possible explanation for these findings, in addition to the fact that the PHQ-2 is not very textured, but it's possible that what we are picking up is a stealing effect amongst people who had experienced far more adversity in the past, which meant that they were relatively less affected than people who had been comparatively protected from economic shocks before. And this is something that I wanted to explore further by looking at whether there are gender differences in resilience among the poor. And this is an interesting question because on average, and this is a really well-documented finding globally and in South Africa, women report far more depressive symptoms than do men. There's a very big literature on this. And I wondered whether the gender gap in depression symptomology is particularly large among adults with low socioeconomic status, whether this helps to account for the gender gap in depression scores. And in order to look at this, we used a novel sorting and classification method. I've given the site there in case people are interested. And I think I'm probably in my last 2 minutes. So the short answer to that question about whether women ruminate more from economic hardship than do men is no, they don't. For the study, we used the NIDS data, which was really like the precursor to the NIDS CRAM. It was the big survey on which we had drawn the sample for NIDS CRAM. We used the last wave, which was conducted in 2018. It's a much bigger sample. It's a much longer survey because it wasn't conducted during the COVID-19 pandemic. And the NIDS survey included the 10 questions that made up the CSD-10. And what we found was that among adults with low socioeconomic status and amongst adults who were identical in all respects, except some were women and some were men, we found that poor women were not more likely to face a very large gender gap in depression scores. In fact, they were more present among the group of women with the smallest or even a reversed gender gap in depression scores. So although women on average report significantly more depression scores than do men in the NIDS data, amongst people who are poor, most women actually reported lower depression scores than did men. But what we did find was that women appeared to ruminate more than men over health issues and over their gender roles. So let me stop there. I think I made it just in time.
Thank you, Dorrit. You definitely made it in time, and what a wonderful presentation. So thank you, because I think it completely highlights the impact of unemployment on mental health. We will take questions at the end. And one that I'm curious about, but to answer at the end, is actually whether you looked at suicide rates and was that different, particularly with regard to gender as well, because suicide rates are also different in the two genders actually. But we'll get to that at the end. Sorry, it was just as I was thinking and before I forgot. We're going to go to the next speaker, Professor Cyprian Mostert. Thank you for joining us, Cyprian. So Cyprian is an assistant professor at the Global Health Economics Department and a chief economist at the Brain and Mind Institute, which is hosted at the Aga Khan University. Cyprian has worked in higher education for more than 10 years and he has just told us has actually started out in the health field before changing to finance and economics. He has worked in global roles on various continents and has lots of experience living and working in several world regions, including Africa, the Americas, and Europe. And his research interests include econometrics, development economics, health inequality, mental health, poverty, public health policy, and health financing. Thank you for joining us, Cyprian. I'll hand it over to you.
Thank you very much, Kirti. I hope you can hear me.
Yes, we can hear you well.
Greetings, everyone. For the title of my presentation, I just decided to basically capture the intersections between macroeconomics and brain health. And what I'll try to cover here is just to look at what has been done in South Africa, but also internationally about that relationship between macroeconomics and health. I will then speak a bit about macroeconomics and brain health and what we see currently in the literature when it comes to climate shocks, which are also linked to economic shocks and how they impact brain health. And then I would likely basically recommend the steps that we need to take forward now in terms of what we can do to improve brain health, purely looking on economic perspective.
Cyprian, just to let you know, the slide is just showing sort of the PowerPoint, not the slideshow aspect of it.
Okay, let me see if I can do this. Is it better now?
No. Is everyone just seeing it like me? Or is it just, if you go to view and slideshow, maybe?
Okay,
I'm not sure.
Maybe click the little icon at the bottom of your screen on the right-hand side. Right at the bottom of there you go. Click that.
Yeah,
try again.
It's not working.
No.
Try F5 on your
F5.
keyboard.
Is it better now?
Still not showing.
No.
May I suggest something?
Sure.
So what you do is you just stop sharing, make it into presenter mode, and then press Control Alt and Tab simultaneously. And when you share, you choose the presenter view.
Is it better now?
No, but I guess we can work with this, but we're seeing the slides like as
I think this is okay with the save.
yeah, it's fine.
Okay. Good. This is the work that I've just recently published, looking at the intersections between macroeconomics and health in the context of South Africa, analyzing cohorts of children between the ages of 15 and 19, but also looking at young adults, which were individuals between the ages of 25 and 32, to really look at whether there is a relationship between what I call brain erosion that you can derive from economic declines. We all know the story of the South African economy. From 2002 until 2007, those were the glory days of the country. The economy almost reached 6%. But then the 2008 financial crisis came, and then the economy started tumbling down. I think now we are also growing at about 1.5%. Really, the economy is stagnating. So my interest here was just to really come up with a link between macroeconomic decline and erosion in brain health. And I found something very striking when you look into the consumptions of substances, especially alcohol. In South Africa, between 2000 and 2004, there was just like modest consumption when you look into the state SA data. But what then tends to happen after the financial crisis, if you look at from 2008 up until 2014, you see this 140% increase in really cases of alcohol abuse, which clearly shows that as the economy beginning to tumble, people are losing jobs, they get more stress, alcohol becomes a safe haven to really deal with what they're going through. And that basically explains these episodes of high consumptions of alcohol, which to some degree explain the depression levels. As you can see from the next slide, when the 2008 financial crisis came, the state SA data shows that the evolution of depression in South Africa.
Sorry, the slides are not changing either. But I don't know that we're going to be able to fix it.
Jeez.
Sometimes technical stuff just happens.
Technology is failing me today.
Yes.
Sorry.
Okay, here's it. Now the slides are changing.
Okay. I will present from this mute. Okay.
Okay.
So you can see after the 2008 financial crisis, when you track the depression cases that are provided by State SA, especially in these cohorts, there's a huge jump that you see, which then explain what has been happening. There's been some level of austerity measures that was implemented in South Africa because of the crisis. The combination of all of that and job losses and the consumptions of alcohol really such this upswing in depression cases. Then we see this association when the economy is tumbling down, consumption of substances becomes a huge issue, and that basically fuel mental ill health and what I call brain health erosions. What is the intersections between climate shock and brain health? I've just delivered a presentation in Cape Town recently where I was attending a World Congress, really showing what happened in South Africa in 2015 and 2019 when we have this day zero because of the great drought that we've seen in Cape Town. There's analysis that we've done as a team here to look at what actually that climate change shock, which is also economic shock because people lost jobs, especially in the agricultural sector, their mental health outcomes compared to the regions that didn't experience the drought, especially like Gauteng and all the green areas that you see from the map there. What we discovered is that the 2015 drought caused an increase of about 8.63% increase in depression cases. And also suicide became increased by 5.33%. And the epilepsy cases is also linked to brain health were worsened by about 4.12%. So we see that intersections between if it's economy not doing quite well, people are abusing substances, but also some of these climate change shocks do affect brain health. And our submission and recommendations here, especially when it comes to the emergency funds, that there's a need to rethink how we prioritize those expenditures instead of just addressing infrastructure investment that comes with whatever destruction. We also need to prioritize mental health issues because we see that people are worstly affected. Primarily, when we're analyzing the data, we see that the primary issues because of this food insecurity. That becomes a big associations that explain the significant jump into depression cases and to some degree traumatic stress and suicide. This evidence basically corroborates what has been seen also in India, especially on the farms, where the massive drought that India witnessed a couple of years ago really drive down, I think, about 4.2% increase in suicide cases because of the state of hopelessness, especially to those who rely on agricultural sector. So those intersections between economic shocks and brain health do exist, and policymakers did need to take a very keen interest into the space. And this is a piece of data that we've just analyzed recently, looking at smoking intensity pre-COVID and during COVID in South Africa. We've got very good data that we were able to access from University of Pretoria, where there was a good comprehensive survey to try to look at the smoking intensity before COVID and during the lockdown period in South Africa. What we see was a massive increase in smoking consumption, and the prevalence was already high. And the number of people who were smoking more than half the pack a day really shoot up because people during the lockdown were under tremendous stress. And the combination of that stress and some of the job losses that we've seen explain basically the highest wave. When we're breaking it down according to race, we've seen it was mainly high from the colored population, where we've seen massive jump into smoking intensity, which to some degree were associated with high depression cases into those population group. What do we do then in terms of recommendation? I've recently published a paper last year when I was just looking into the social security system, but primarily on the pension, which we know it is a vehicle in most households, especially in South Africa, that are poor, that they rely on pensions basically for their survival. We did an analysis to look at what was the impact of the social pension reform in South Africa when we were harmonizing the eligibility criteria between men and women. As you know, now in South Africa, everyone from the age of 60, they can basically file and apply for social pension. We then captured that intersections, what it actually was able to do to the mental health of men. And we did manage to see significant results that harmonization in terms of eligibility criteria did improve depression and traumatic stress, especially from the male population group, which was also associated with massive improvement in suicide. So then we're able to really see that there is a greater need to look into the economics of improving brain health. And one of it is to look in vehicles or instruments like cash transfer, which we know the instrument that also the World Bank advocate for as a mechanism to avoid poverty, but also social pensions, like I've mentioned here. We do have seen that intersections that social pensions do affect mental health. But also the substances you cannot really do without, because we see them as gateway that to some degree have this compounding effect that results into brain health erosion. So what are my recommendations here? We do know that the cash transfer, as I've said, is very much popular among developing countries, but there's a greater issue when it comes to cash transfer because most of them are not inflation indexed, including South Africa. It is the treasury that looks into the fiscus and then decide that, okay, based on the money that has been collected, we think there will be a 10 Rand increase into cash transfer policy. But in most instances, it has not been tracking the inflation. The danger of that is that the purchasing power of the money gets depleted each and every year, and then it does not becoming very much effective in reducing poverty levels, which I think down the line it will then influence mental health outcomes. Like I said, social pensions for the elderly, we've seen evidence that there's an association with that. Early pension payout does improve mental health. And most of the government, especially in Africa, they're still pretty much stuck with men retiring or accessing their pension a bit later compared to having a more harmonized pension systems. And one of the recommendations that needs to be looked into is how do we do that? Because that evidence is there that early pension payouts does improve mental health. Like I said, we can't do anything focusing on social security system. The intersections between economic decline and abuse of substances there, and we need to look into how do we reform our alcohol policy to make alcohol also very expensive, that when people are going through these stresses, but it's not becoming easily accessible to consume alcohol. And one of the recommendations that I've also made is also tobacco. Tobacco is the gateway by far that influence and erode brain health. And there is an evidence that has been published by World Psychiatry. They've really debated extensively whether tobacco does erode brain health. And the evidence is that, yes, it's there. And the scholars was mainly debated in terms of causality or do we have the reverse direction. But at least there's an admission that there's evidence that it does influence, it affects negatively brain health. So there's a need to also look into those spaces to really make sure that we're dealing with substances. Food security, like my previous speaker has covered, which also and most of the time is linked with jobs, becomes a very important issue, especially for the poor. In our submissions that we've made in one of the paper we've written was to government really to look into what I call the zero rated VAT basket, to really expand it, because the intersections between poverty, economic decline, and mental health is there. We really need to protect the poor. So in our submission is that we really need to look comprehensively into these issues, because we do believe that they will play a more meaningful role in improving brain health. Thank you very much. I hope I was quick enough to wrap it.
Thank you, Cyprian. No, you were definitely quick enough, and actually quick enough, but really also showed us the thread, you know, the economic vulnerability, the impact of mental health and brain health, the link with abuse of alcohol and other drugs. And sometimes we look particularly at abuse of alcohol and drugs as a very separate issue, but it really is linked. And if we do want to sort out both improve mental health and drug abuse, we actually need to improve our economic situation really for the most vulnerable in our societies. So thank you very much. We will get to questions at the end of Madhavi's presentation. So our third speaker for the day is Professor Madhavi Bhargava. I'm saying it slightly incorrectly, apologies. An associate professor at the Department of Community Medicine at the Yenepoya Medical College in Mangalore in India, and deputy head of the Center of Nutrition Studies. And her current work focuses on the intersection of TB and nutrition as the co-principal investigator of the RATIONS trial, which is really a very important trial. And it showed the importance of nutrition support in preventing TB in household contexts, but also improving outcomes in people with TB. Other interests include public health nutrition, the social determinants of health, and public health in low resource settings. Thank you, Madhavi. I'm going to hand it over to you.
Yeah. So let me just check my slides are moving or not.
Yeah, they're moving and presenting. So
okay, cool. Okay, great. So RATIONS stands very beautifully for and appropriately for reducing activation of tuberculosis by improvement of nutritional status. And I would declare that I have no conflict of interest here. Before I share the findings of the RATIONS trial, what we need to understand is that why is it that some people get TB and only some develop very severe TB, and out of that, some die. So even for those who are not clinicians, this X-ray shows terrible destruction on one side of the chest of a 14-year-old child who is a contact of a patient with TB in the area where I worked in Jharkhand. So Edward Trudeau very rightly said that there's a rich man's tuberculosis and a poor man, and the rich man recovers and the poor man dies. So poverty, undernutrition, TB pathogenesis, and the outcomes, they are very closely intertwined. The people in poorer communities, they are living in tuberculogenic environment where they are living with people who have tuberculosis, infectious tuberculosis, sometimes advanced diseases. Also, there is overcrowding, poor ventilation. As a result, they have greater exposure to infection, and they have greater vulnerability due to various risk factors to progress into a disease. That is malnutrition, alcohol, smoking, HIV, socioeconomic distress. And we have seen through previous speakers, they are all intertwined. Their poverty affects the ability to reach the diagnostic facility, their care, how they progress during the treatment, the costs that they incur, and the loss of job. And finally, when the treatment is over, the whole the reason for getting treated is to become productive. But if they do not come back to work, what is the point of the treatment? So all these differ when it comes to rich man's tuberculosis and poor man's tuberculosis. And although it's a very well-known factor in TB, that people lose weight during tuberculosis. Now it is also well known that it's a risk factor for development of tuberculosis. There are other things that are important, and that is it affects the severity of disease. It also affects the drug absorption. So when I take TB medicine and when a very thin undernourished person takes medicines, the effects are different. And of course, there is a possibility of relapse when people are undernourished. And there's always been a debate whether it's, the TB causes weight loss or the weight loss leads to greater possibility of tuberculosis. So that chicken and egg story needed to be answered, and RATIONS was basically an attempt to answer those questions. It was a large trial which covered 2,100 square kilometers in a rural and tribal area of Jharkhand. 4 districts we covered, and it coincided very well with COVID pandemic. A cluster randomized trial during COVID was a nightmare, but we could survive it. And Jharkhand is a very beautiful state with rich natural resources, but a huge disparity in terms of access, livelihood, and many difficult to reach areas. Here I would like to take a minute. I'll be presenting findings of basically two important populations within the trial. One is the 2,800 patients with tuberculosis, infective tuberculosis. So as and when they were diagnosed in the national program, they were enrolled in a trial from these 4 districts. And depending on their intervention in the control arm, their household contacts were randomized into 2 groups, that is the control group and the intervention group. So there were about 10,345 household contacts. Our primary objective was to look at the difference in the incident cases in the household contacts. The hypothesis being that if we give good nutrition to the household contacts in intervention arm, do they develop less TB in spite of having an infective case of TB in the household? There were secondary objectives mostly related to the patients, 2,800 patients, that is the mortality, their weight gain, their ability to work, their BMI, and a loss to follow-up and side effects to drugs. So all those things that I described were to be answered by this trial. For ethical reasons, in patients, we did not have a control arm. So both the patients in both the arms received a food basket of 5 kg rice, 3 kg pulses, and milk powder to provide high protein diet, along with some oil and micronutrient pills. And in the intervention arm, apart from patients, each family member also got rice and pulses, along with micronutrients, for during the treatment period, that is 6 months of treatment period. So this was to provide extra calories and proteins during the treatment period of the patient, which is usually 6 months. So it can be called as an 1,100-ton study. We distributed a lot of food during those 6 months, coinciding with the COVID pandemic. But more importantly, the cost of the basket, if we look at those, the cost during those times, the patient basket costs a nominal 1,100 rupees per month, and adult contact 325 rupees per month. That I will come to US dollars for easier understanding when it comes to prevention. So over 3 years, we followed up these these households. The enrollment got a little delayed because of the pandemic. We did various baseline evaluations. Most importantly, we did anthropometry. We looked for oxygen saturation, and we looked for a very simple indicator of ability to work. So this is Eastern Cooperative Oncology Group score, where 0 is people like you and me who are able to work, and progressive numbers indicating inability to do self-care and work. We triage patients to look for severity so that they can be saved from TB mortality. And these are some pictures to indicate the measurements in the field. The outcomes, out of all the 10,345 household contacts, we diagnosed 218 cases of tuberculosis, and 96 in the intervention arm, 122 in the control arm. Although these numbers look, the difference in the number looks small, if you look at the adjusted incident rate ratios, it was 39% reduction in incidence in the intervention arm. And if you look at the lung TB, that is those that were diagnosed definitively by using sputum, that was 48% reduction in incident TB. And other figures are there on the slide. If we look at the characteristics, I will not go into the detail, but there were under 5 also, there were adolescents, and there were adults, 177 adults. The weight gain in the household contact was pretty modest, I would say. We expected a little more, but during COVID pandemic, probably the baseline intakes went down. So the weight gain was only 1.6 in intervention arm, and control arm was 0.8. If you look at the children, the difference is not much, probably because of food sharing in the control arm, which was very likely. If we look at the patient outcomes, the treatment success was 94%, weight gain was 4.6% overall, and the unfavorable outcomes were much less than other studies that have been published in India. And most important here that I would like to highlight, apart from other things, was that a very modest weight gain of 5% in first 2 months reduced the hazard of death by 60%. If we compare to the recent cohorts, again, here there are other things, but there are a lot of patients in India who have adult patients of TB who have less than 35 kg weight, and there the hazard of death was reduced by almost half. And when we started, there were 3% patients who were able to do normal work. At the end of 6 months, there were 75% who were able to do work. And that was, I would say, our biggest achievement. There are key learnings in TB prevention and then in TB care. So in prevention, the efficacy almost reached the recently developed vaccine, almost, and WHO product requirement for a good vaccine is 50% for tuberculosis. So it was reaching that. And when it comes to care, there are a lot of learnings. We are, with just 5% weight gain, we are able to reduce TB deaths. Comprehensive, simple evaluation like blood pressure, saturation, BMI, ability to stand, work, etc., which can be easily assessed by field workers, can prevent TB, can be used as a triaging tool, and this can be an important complement to TB prevention treatment. We are not saying either and or, but it should be added to the TPT. So coming to the economics of it, I just did a back of the envelope calculation. So preventing one contact into developing tuberculosis, we need to spend about $2,608 for preventing one TB death. It is $3,870. And if we look at those who are severely undernourished, that is 35 kg weight, absolute weights, it is just almost $1,000. So these are not very big numbers. If we look at the development cost of new drugs, the MDR drugs, the diagnostics, etc. So thank you very much. This was all on behalf of my team and the communities from whom I've learned a lot. Thanks so much. I hope I did not overshoot the time.
No, I think none of you did. Thank you, Madhavi, for an excellent presentation. And what remarkable findings. And again, I think also being based in South Africa with high levels of food insecurity, particularly in populations you do see who come to hospital who are sick, they have higher levels of food insecurity. I think the question is whether we should be dispensing food when we understand food insecurity is so high. And I think your study actually shows that, and that's why I invited you. It's not directly related to brain health, but it is something we need to include in terms of brain health and mental health outcomes, whether it's more effective or, like I say, it's not either or, but sometimes I remember we had to actually, somebody comes in with these social problems and we refer to a psychologist or an economist. We refer to a psychologist, social or economic problems. and whether it's more effective in that setting to actually dispense food or a social grant, as you were saying, Cyprian. We're going to open up for questions. Wembui, are you going to manage the questions for us, please? Hi. Yeah. I see Alfred. Alfred, do you want to go ahead and ask? Wembui, can you change the settings on a... Okay, perfect. It's working. Okay, cool.
Thank you very much. This has been a very, very interesting session. And thank you again, Kirti, for choosing these experts to give us these presentations based on evidence. It turns around the whole question of brain health or mental health, which we consider to be part of brain health, to be basically a developmental problem. We've seen the effect of lockdown on depression and mental health. We have seen the evidence of the economy on brain health. And even though you were mentioning, Kirti, that nutrition is not directly related, I would argue that it is directly related. It's directly related, even in the young ones, nutrition, and in old people and disease. I think we've had the evidence. My question is, especially for the second speaker, Cyprian, most of the recommendations were policy improvement. I wanted to hear from all of you, especially Cyprian, if there should be no recommendation in the direction of creating jobs and then helping people to maintain them. When we look at our continent, Africa, it could produce enough food for everybody. And we are not producing that food, even though, and when we look at what the African Union aims to have for us in 2063, food security, health, and all of these things are the aims. But I'm happy to see this data because I was wondering whether the university researchers, the academics actually know where, as a continent, Africa wants to get to, and who is actually working and producing the evidence that will be translated into policy and implemented for us to acquire healthy citizens and good working conditions, in spite of the changing climatic conditions and many other disasters that we may not have direct control over. It's a very convoluted question, but in comments, but I hope that the expert and very good panel can be able to give us some ideas or some suggestions on that. Thank you again very much to all the panelists, and thank you for organizing, Kirti.
Thanks, Alfred. I wonder if we can ask all the panelists to just put their videos on just for the questions session. Thank you.
Okay. Thanks, Katie. Just a quick reply from Prof. Alfred. I would always advocate for more jobs to be created. The continent needs those jobs more than ever. And we know the intersections between employment, as my speaker also showed, that it's got some cushioning effect in assisting people to cope with mental ill health. So we need a lot of that. And I agree that when it coming to strategic direction where the continent needs to go, there's a huge vacuum in terms of policy work, in terms of really grinding the economic evaluations that can feed at a continental level in terms of what needs to be done. But also, an interesting question also arises then when we try to look at economics of brain health and also looking into the investment case for mental health, which are being generated all over the place. There will be a need for us to look more thoroughly and more honestly whether if we have $1, where is it more effective if we're plugging it into the health system with the intentions of improving brain health, or we will do better in really addressing the socio-economic status, the jobs, the food, the poverty, and all of that. And with the view that the multiplier effect that will be generated from those investments on the social level will have mitigating effect down the line. So that's the very interesting debate that as economists we need to engage to, because we might find that social investment has a more powerful impact in improving mental health than bulking all the resources into a hospital. Because the evidence seems to suggest that a very hospice-centric health system, yes, it does improve outcomes, but it does lately. And quite honest, it does not become sustainable. So those are the questions that I'm putting out there that I think we need to take this debate into, because I think we might be in a very perfect space to really advise our governments in terms of the whole economics of brain health and what we need to be doing. I hope I've tried to really squeeze everything that you've asked from my input. Thank you.
Thanks, Cyprian. I think I agree as well. I think it is time we started looking at that, particularly in terms of so much of what's not being done in our health systems, and yeah, which is a whole different discussion. Any other questions? Okay. Scholastic, Adele, you can unmute yourself and go ahead and ask.
Yeah, thank you so much for the presentation. Really creating a lot of awareness. But looking at the presentation on macroeconomics and brain health, a quick question again is from Professor. Do you think social pension can actually improve mental health of senior citizens? Do you think social pension, as you presented, is it the only thing that can improve the mental health of senior citizens? And I would want to say generally in Africa. Over to you, Prof.
Thank you very much, Scholastic, Adele. Good question. I will say social pension do play a meaningful role. My analysis points that they do improve depression, traumatic stress. To some degree, it is associated with improvement in elderly mortalities. But we need to do much better. I mean, few African countries have comprehensive policies that deals with dementia. So the pension, while it can be a very good instrument to deal with their poverty at the household level, but we still need more investment that comes to the space to really look into the health of the elderly population, which the African Union has advocated quite strongly, that governments need to put progressive policies to deal with the mental health of the elderly. What we tend to see also in SA from the data that I've analyzed is that when there was this eligibility criteria, which was now harmonized between males and female, because my analysis was just looking at the mental health of men, there was an improvement there. But also, if you look at the female population, which are the grand women who have benefited from pension early, it seems as if there is some level of a compounding effect that they've been benefiting from because of the former policy, how it is been structured, which to some degree does explain the differences in terms of mortalities between males and females, especially from the elderly population. So they are a good instrument, but in Africa, what we see in the continent is that few countries have implemented social pension. Some countries don't have those pensions at all. I can quote, for example, Swaziland. It does not have. And there's some countries also in the continent that, even though they pay pensions, but they come very, very late. One classical example you see in Kenya, for example, where I am, that the pension payout comes at the age of 65, but life expectancy is at 62. At some point, it was 51. Who was going to benefit from those pensions? Because the people would be all gone. There's a need to rethink all those policies to make them more progressive so that truly we address the mental health of the elderly population. Thank you very much, Scholastic. That's my input.
Thanks so much, Cyprian. I think staying with what you mentioned in terms of the gender difference and the compounding effect, Dorrit, I'm going to come back to you in terms of the question I had. Did you look at suicide rates and whether that was different in in your research in terms of the gender differences?
No, we're limited by what data we have. So we don't have macro data on suicide rates. No, we didn't. It would be great if we did, but
Yeah, and I was just curious because suicide rates are generally higher in men. And so while depressive symptoms may be higher in women, it would be interesting to actually look at and compare.
It's the same paradox that you get on self-reported health. Women report worse self-reported health, but men have higher mortality rates.
Interesting. Interesting.
I just wanted to make a quick comment about creating jobs. I think that is the million rupee question. South Africa has been trying to create jobs over the last 30 years. It's not just that you want to create jobs, you want to create good jobs. Really bad, dehumanizing, low-paid jobs, it's not clear. I'm not sure that research shows that is really protective of mental health. So that is the big problem for South Africa. I think there are many economists who would say that's the source of all our socioeconomic medical health, etc., domestic violence problems, that we need to create jobs, but we just aren't being very successful. And that would be the topic for a whole series of webinars. We don't have an answer.
I agree. I'm wondering what the economists are doing, but I could say the same thing about the health system, so we won't push on that. Madhavi, do you think we should start looking at actually dispensing food with treatment, with medical treatment to improve outcomes, even if we haven't actually done the studies in everybody?
So there are 4 or 5 important risk factors when it comes to tuberculosis, and so wherever there is HIV, already I think the food support systems are in place. But when it comes to undernutrition, in country like India, where the HIV burden is not much, but the undernutrition burden is much higher, and we have done another work where we have shown the attributable fraction for TB. It's almost 30 to 40% in India. So, and India is a continent, so there are pockets where there are problems of overweight, obesity, but there are huge geographical areas where we have a lot of undernutrition. So we have been advocating for this for last 20 years almost. And in 2018, the government has started cash benefit transfer, although we were in favor of food baskets. But because of various logistics they converted into. But what I like about what Cyprian said was the inflation index cash transfer. This is something I'm going to latch on to when I advocate with our government, and because it's really a very measly sum that comes, and also comes very late. But coming to your question, yes, we have been doing a lot of post-trial advocacy along with the government of India, and there has been a lot of interest, and we have been able to make food support a sexy component of TB treatment. So now a lot of people are, I'm sorry to use that term, but now a lot of local governments have started giving this food support, even for the sake of photo ops and all. So it's in a very small scale, I would say, looking at the problem in India, but it is picking up, definitely. And now we have evidence, so there is no way. And the advocacy at WHO level has also succeeded. So we have had presentation with global TB people. So let's see that if it comes, we were able to have, a representation in the Lancet Commission. So probably it has reached, so yes, nutrition has figured in Lancet Commission for tuberculosis in 2023. So definitely it got some voice in the UNHLM as well. So let us hope that it works, and works in most part of worlds where TB and undernutrition are, going hand in hand.
Thanks, Madhavi. And I'm going to come back to you about that one if we do have time, whether we should actually start giving people admitted to hospital nutritional support. Smangaliso, do you want to unmute yourself and ask your question?
Hi, Kirti. Thank you. It's kind of a long question now, and maybe, let me just read from the chat. So my I'm from the social sciences, and my question is always, especially when we are talking economics and when we are talking brain health in this situation, because my question comes to social constructs, right? I think we can all agree that there are certain social constructs that are involved in, say, achieving self-efficacy, for example, for the poor, right, and achieving resilience. So my question is to the economists, especially at that macroeconomic presentation, what sort of social constructs do economists see coming up more frequently than not in talking about the role of social investment in South Africa and Africa in general? So the hope is that maybe there's a way in which social scientists and economists can engage to create sort of frameworks and metrics to measure that relationship, for example, in terms of financial or economical progress.
So I think Cyprian and Dorrit are the economists. I'm going to hand it over to you. But Madhavi, feel free after them as well if you want to add something to that.
Well, I'm not sure that we both understand what you mean by social constructs in this context, but I would say that there's a very well-documented relationship between many aspects of poverty and people's well-being, and there's a whole literature, for example, on how the dwelling that you live in affects your mental health. You know, that whether you live in a shack without running water and without services and without privacy and overcrowding, and how that affects social cohesion and well-being and depression and purpose. So I guess really I think the root of a lot of this is giving people the right to be able to earn a living and to have an economically meaningful life. But I think that that is layered by the different responsibilities that men and women have and the different access that men and women have to the labor market. So I would say there's no easy answer, but yeah, a lot of it lies with what's happening in the labor market and people's access to jobs. Social grants would not be so important in South Africa if people had access to employment, you know, and people would then have access to pensions and the kind of security that they need. Yeah. So there is lots of literature which recognizes the implications of poverty beyond the economic implications that many economists focus on. Yeah, I feel like it's a mountain of a problem. I just wanted to respond quickly to Johanni, who has a question above that, and I think it's a great question. And it's
sorry, Dorrit, I'm going to pause you one second.
Sure.
I'm just going to ask Jo to verbalize her question, and then we'll get back to you answering. Jo, do you want to unmute yourself and ask the question?
Thank you so much. Yeah, I think Madhavi just touched on it as well. But my question is, with all of the discussions that consistently revolve around food insecurity and how this really deeply impacts mental and physical well-being, I struggle to wrap my head around just how much billions of dollars are circulated into mental health research that is not focused on food sovereignty. And I just wonder why it is that so much money is being pumped into understanding small, nuanced, population-specific directives rather than just trying to implement actual societal change by creating that sovereign kind of food economy, especially something that is locally thriving.
And particularly in the context of climate change, absolutely. I mean, we need political will as well and political capacity, I guess.
Madhavi, Cyprian, do you want to respond to that?
Yeah, I mean, I know it's a question and a comment, and it's true, and we are always focused more on, you know, as healthcare providers, I feel there's a lot of fancy towards technology, diagnostics, therapeutics, of course, influenced by the industry pressures. and that also makes, takes the direction. The industry decides the needs, and industry does not want to provide food. And when we started this trial, we were, caught up between ethicists who said that, do we really need to prove this obvious thing? The activists were angry with us that why a food trial? On the other hand, the governments or even the WHO was not talking about nutrition in a big way. So we had to do this trial once and for all to answer this question, whether it is chicken first or the egg, and to say that, yes, it is as good as vaccine. And the most important thing, we have been engaging, the way we have been engaging with the government and various partners is, we are not saying either and or. We know therapeutics are important. We know diagnostics are important. We know preventive treatments are also important. But we know that the underlying thing in any of this is poverty and undernutrition. And unless we address that, we cannot be successful with the best possible medication. We have resistance towards delaminate, which is the best drug right now for MDR tuberculosis. So what are we talking about? What are we going to give as a preventive treatment to the contacts? The only thing that is available is food. There are no guidelines at the moment. So I know what you are trying to say is it's a rhetorical question, and it's actually collective frustration with that, and we have to create, channelize that frustration, creating good evidence like this, and vocalize basically.
Thank you so much, Madhavi. Cyprian, do you want to comment on this and the previous question from Smangaliso?
I think my colleagues have just covered it more comprehensively. The way I look at it, I keep telling some of the students that I work with, like, development economics is meaningless if we have not addressed basic food, because with food, society will thrive. Everything will then follow. We spend so much time trying to treat diseases on the bedside. Bulk of the problem comes at the household level. If people are given food, there's enough proper shelter. It's not so much about social construct. I don't think we need to theorize that. It comes to a basic fundamental principle, because all of us, we are here to exist. And for us to exist, we need some form of a social compact that can address things like food security, education, health, and then society will flourish. The danger is that we are living in a capitalist society. If I have to give you my view, I think capitalism is one of the most evil systems that the humankind has ever devised, because it is pointless to live in a country or in a continent that has all the food, but it has so much grinding poverty, because food is concentrated in few industries, and those industries are doing nothing to distribute it equitably, even running successful businesses and generate revenue from that. We don't see that. So ultimately, it needs a very significant shift in how we think about economics. Well, it's a Latin word that says the study of lack, but surely we can really do better to really be equitable and really set our society into a positive base. Creating jobs is not something that we need to theorize about. It we need to be practical. And I think the continent is in a very perfect position to do so much without really requiring much. Like Professor Posel mentioned, we just need a political will. We just need political will, and the people who've got deep pockets to also come to the party to understand that no one is truly free until all of us are free. So we can have money and build high walls because we're trying to run away from the other guys that can come and steal our food in our fridge. But imagine a society when food was not an issue. Maybe we'll be discussing different economics. I think that's a world maybe in my loudest dream I'm really trying to envisage. And I think that's when most of these issues will be sorted out. I think that will be my contribution to this line of question. Thank you.
Thank you, Cyprian. Definitely aspects. I mean, if you think of just Joburg, and we had the richest seam of gold in the whole world. This is where we at as Joburg. It says all the problems with capitalism, really. Alfred, last question for the day, unless I missed somebody. Alfred, yeah.
Really not a question. Okay. Just a few seconds. I can't agree any better with the panelists. I think that I am really excited to see this evidence come out. because if we need to change the way politicians think, the way business people think in India, in Africa, India is ahead of us with that. We need to put the evidence on the table. Someone has said that politicians don't listen to what you say. They feel the heat under their chairs. And one of the ways we can put the heat under their seats is to provide the evidence that something is wrong here, and this is how it can be fixed. So I wanted to really thank the panelists for providing this evidence, and I think that's the direction we should be going. Providing the evidence that can heat up the seats of the politicians, that would compel them to understand the issues and change the policy, so that a continent like ours that is very rich does not have many people suffering because they are poor. Thank you.
Thank you, Alfred. I'll open it up for any more comments before I close. Andre, I was curious. For people who joined late, Andre is the head of neurology at the University of Witwatersrand, and I'm putting him on the spot a little bit. But Andre, we basically work at Chris Hani Baragwanath Hospital in Soweto, and a large number of the people we would see would be income and food insecure. And it affects health outcomes. It affects access to, just to get to the hospital, as Madhavi was pointing out. And I just wanted to know what your opinion was, or your comment from this discussion.
Yeah, Kirti, thanks. I was itching to put my hand up about this TB treatment together with food. And even Madhavi said it's a sexy thing to do, because imagine you get food together with the tablets. Instead of being ousted and outcast, you actually get something that brings more even to the whole family. I know they're going to share it. It's not only that person going to eat that food. So I find this amazing, Madhavi, that initiative. The problem is, if you convert it into cash, it would be spent on alcohol. And in South Africa, and I'm sure Cyprian would agree with me, it will be sold for cash to buy alcohol or other recreational activities. So it's an issue that we need to dice carefully. But I think the general idea is stunning. And if you look at your numbers, I mean, it's not numbers needed to treat, but numbers needed to screen. I understand this whole issue is actually highly favorable in favor of doing this. So and the cost is really bearable. So I find, Kirti, ourselves, even look at what we call our townships. I mean, there's definitely, if you throw a sack of maize meal here or there into their TB treatment, I think it would make a big difference in terms of both compliance and actually the after effect of having nutrition. So I think that's an amazing avenue to pursue. So thanks for that input. And I truly am not that well read to have followed all of this. So it's great eye-opener to me. Again, so the panel and everyone and my colleague from WITS, amazing facts that have been displayed. So I think we must just put this into action. But I think, to be honest, at the bottom of all of this needs to be bringing people up by education, and that is what is going to grow jobs and what is going to grow the economy. So that is my little by the side unqualified comment. But thanks for this eye-opening session, everyone.
Thank you, Andre. I think we'll have to have another discussion on what education actually is. So thank you to everybody who joined. Thank you for your insights and your comments. And thank you especially to the panelists, Cyprian. Thank you to Dorrit. Thank you to Madhavi. Really, what an insightful, provocative panel discussion. And given the work that I'm doing in terms of brain health, I just think we need to really make it central to the way we approach brain health as a public health issue, really. So thank you. I think you really showed the link between unemployment, between food and income insecurity, and mental health or brain health outcomes, and then potentially solutions in terms of the social security grants or dispensing food, which sounds so simple and is so incredibly novel in the systems that we work in. So thank you again. The next Brain Health Perspective series will be on the first Tuesday in October. It will look specifically at issues or challenges and priorities within neurological illnesses.
November,
and there'll be an exciting panel. November, sorry. In November. So do join us. Do follow me or the Africa Brain Health Network on Twitter or on LinkedIn to actually keep up to date with everything that we're doing. And yes, thank you again. Enjoy the rest of your
Thanks for the opportunity. Good to meet everyone. Bye all.
Bye. Thank you so much, everyone.
Bye. Bye.
Bye.